Hi nursing students, this is Professor Booth, and today's recorded lecture is on an introduction to pharmacology. Today's learning objectives come straight out of your review module book for PN Pharmacology for Nursing Edition 8.0 and also the review module Pharmacology Made Easy 5.0. These are the things that I want you to know when I'm finished with this lecture. Pharmacological principles that I want you to know is that pharmacology is the study or science of drugs, and a drug is any chemical that affects the physiological processes of a living being. Now, there are many sources of drugs. We can get drugs from plants. Poppies can produce the drug opium. Foxglove can be used in digitalis, which is a cardiac drug, and white willow bark can be found in aspirin. Drugs can also come from animals. We get insulin from cows and pigs. We also get thyroid medications and growth hormones from animals. Drugs can come from inorganic sources like aluminum, iron, and gold. Those can be found in medications. And medications can be sourced synthetically, which means we use genetic engineering to create drugs. Medications are split up into different categories. Usually medications in the same category act in a similar way, have the same kind of adverse drug reactions, contraindications, precautions, and administration considerations. There's going to be a whole lot of medications that you're going to be responsible for, so it's much easier to learn medications according to their category because they are similar instead of learning each one individually. After you learn a particular category, then you learn specifics about some of the medications in that category. One way that we categorize medications is by their generic versus their brand or trade name. It's important that for your nursing practice, you are familiar with both generic names and brand or trade names, but for NCLEX exams, they use strictly generic names, and I will be using the majority of generic names for my exams as well. So how do they get a generic versus a trade name? When a pharmaceutical company develops a medication, they give it an official name, and that becomes the generic name of the medication. When you name something generically, it will not be capitalized. However, those same companies can create a commercial or proprietary name, which we call the brand or trade name, and that is specific to the company producing it and marketing it. Those names, the brand or trade names, are capitalized. An example of a generic medication that you might know is acetaminophen. It's not capitalized. It has a lot of letters in it, but its proprietary or brand or trade name is Tylenol. We also have ibuprofen, which people take for headaches. That's a generic name. It's not capitalized, but it's also known as Advil, which is capitalized with an A in Advil. There could be several different brand names for one generic medication depending on who manufactures the medication. Each company can give the medication their own brand or trade names. That's why we like to stick to the generic, because it's one name for many different companies who produce the same medication. Those generic or brand or trade name medications usually have the same chemical composition. There's no difference in the potential for abuse or dependence between the generic name and the brand name of the same medication, because the FDA makes sure that generic medications have the same therapeutic equivalence as the brand name medication. There are three main areas of pharmacology, and I've also added pharmacotherapeutics to the end of this slide. First up is pharmaceutics. That is how various drugs forms, whether it's a tab, whether it's taken as a liquid, whether it's an injection or a transdermal patch, how those various drug forms interact in the body. It talks about how the medications are dissolved and how they are absorbed. Dosage form determines the rate of dissolution, how fast they dissolve from their solid forms, and how fast they're absorbed in the GI tract. This impacts the ability to crush certain medications because they would be absorbed too quickly. We also have medications that are enteric coated, or EC. Those are medications that can irritate the stomach or be broken down by stomach acid. So there's a coating put on them so that they don't break down until they're in the small intestine. We also have extended release forms of medications, or ER or EX medications, that have different sized little blobs in them that is in a capsule that when it opens up, they dissolve at different times because they're different sizes. And that gives us a medication that's going to last for a lot longer. So pharmaceutics is how medications are administered to our body. Next up is pharmacokinetics, and that is what the body does to the drug as it moves throughout the body. That can be broken down into absorption, metabolism, distribution, and excretion, which we'll talk about in following slides in detail. Pharmacodynamics, on the other hand, is what the drug does to the body as it moves through it. So pharmacokinetics is what the body does to the drug, and then pharmacodynamics is what the drug does to the body because they each have an effect on one another. Finally, there's pharmacotherapeutics, which is our expected drug actions. When you take this drug, what should the drug do to the body? That is our therapeutic effect. When the drug is doing what it's supposed to, that's a therapeutic effect. However, when the drug causes something that is not intended, that's considered an adverse effect. It's something we don't want to happen, but can. I like the picture on this slide because it gives you the three main phases or principles of pharmacology, from the drug administration, how it disintegrates, and how it's different depending on which area of the body it's working on. You've got the pharmacokinetic phase, which is broken down into the mnemonic we use for that is ADME, for absorption, distribution, metabolism, and excretion. And then you have the pharmacodynamic phase, which is where the drug actually acts on the body, and it can be a therapeutic effect, which is what we want, or a toxic or adverse effect, which is something that we don't want the drug to do. This has such a weird spelling, but it's pronounced pharmaceutics. And that is addressing how various medication forms affect how it dissolves in our bodies. And how it dissolves can affect how fast it is absorbed and how fast it starts to work. How fast the medication starts to work is called the onset of action. Most of us have taken a pill or an oral liquid by the mouth. Those are called oral medications. They can come in tablets or capsules or powders or liquid forms. We can also take some medications through the mouth, but inhale them into our lungs, and those are usually going to be in powder form. Now, depending if you have a tablet or a capsule or a powder, that's going to influence the rate that that medication is absorbed. We've already talked about some medications like ibuprofen, which has an enteric coating on it because ibuprofen can irritate our stomach. So we put this coating on it so that it doesn't start to dissolve until it gets into our small intestine. Extended release medications, like we said, release over a period of time. So depending on which form it is, depends on how fast that medication starts working and how fast it's going to, or how long it's going to last. Other terms for extended release medications include length, abbreviated as XL, it works over a long period of time. Sustained release, abbreviated as SR or XR, and sustained action, abbreviated as SA. Some oral medications also come in an immediate release form, which expedites the release of the medication after it's swallowed. It works immediately. Oral disintegrating tablets dissolve in the oral cavity. That's something we could put under our tongue, like nitroglycerin. Tablets can be scored, which means they have a line in the center of them, and those can be split in half. That's why it has that little line. It makes it break evenly. although sometimes tablets can be crushed if a patient can't swallow them or if we can't take a liquid form of the medication. However, we never, ever, 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 ever crush anything that is extended release, sustained release, or if it is enteric coated, because then we are causing the medication to be absorbed quicker and in a place where it's not supposed to be. So we talked about oral medications, medications that we take through the mouth. There's also parenteral or injectable medications, which is not going down through the GI tract. Parenteral medications are usually injected into a vein, which is commonly abbreviated as an IV medication. It can be given into the subcutaneous tissue, which we abbreviate as subcutaneous or sub-Q. We can also give parenteral medications intramuscularly into the muscle tissue, which we abbreviate as IM for intramuscular. Parenteral medications typically come in either a liquid form, but they can come in a dry powder that has to have liquid added to it. When we add liquid to a medication so that we can give it, we call that reconstitution of that medication. How fast the medication works and how fast it's absorbed depends on which method we use to give the medication. When we give a medication intravenously right into our IV, that absorption is usually immediate and complete, which means we have a very fast onset of action. However, when we give medications in the subcutaneous tissue, which is fatty, or the intramuscular tissue, which is our muscle tissue, the absorption rate can vary. Usually takes a lot longer than IV medications. Medications can be either water soluble or non-water soluble, which means that they are able to dissolve quickly in the water, and that's going to affect how fast the medication works. Another factor would be how fast a patient's circulatory blood flow is and how fast their tissues perfuse, right? So if you have good blood flow and adequate tissue perfusion, medication is going to be absorbed rapidly. But if you don't have good circulation and you're not able to get oxygen to your tissues, the absorption of that medication is going to be a lot slower. Finally, you can have topical or transdermal medications. Those are medications that you apply directly to a client's skin, their eyes, their ears, their nose, their rectum, their vagina, or lungs. Topical medications usually deliver a constant amount of the medication over an extended period of time. They take a lot longer to start working, the onset of action, and they usually have a longer duration of action than oral or parenterally administered medications. I like this slide for our visual learners because this is the phases of pharmacokinetics. We've got our pharmaceutics, which is how the medication is administered. Then we've got our pharmacokinetics, which is how the medication is absorbed, distributed, metabolized, and elimination. Sometimes I call this ADME because that adds the pharmaceutical part to the pharmacokinetics, and we've got our first two major parts of pharmacology right down in this little slide. After pharmaceutics, or how a medication is administered, we've got the first phase of pharmacokinetics, which is absorption. Absorption is the transfer of medications from the location where they were administered, our pharmaceutics, and that could be the GI tract, into our muscle, into our skin, into our subcutaneous tissue. It's how those medications are transferred from where they were put in our body to how they get into our bloodstream. When we say we're putting that medication into our bloodstream, we call that our systemic circulation. It's going from our GI tract into our circulation, our blood vessels that go all throughout our body. Whether a medication is administered through our GI tract, an enteral medication, or if it's administered through injection like parenteral medications, that gives unique patterns of absorption. So the route changes how medications are absorbed in our body. When you take a medication orally or enterally, they have to pass through that GI tract through a layer of epithelial cells that line our stomach or intestine to get into our bloodstream and our circulatory system or our systemic circulation. Because oral medications or enteral medications have to go through our GI tract first, there are lots of things that can influence how fast and how much gets absorbed through that layer of epithelial cells into our blood circulation. If you have a fast gastric emptying time, that medication is going to go through your GI tract much faster. If you have a high pH, that medication may be broken down faster and absorbed differently than if you had a regular pH. If you have food in the stomach, that may affect how fast that medication that you've taken by your mouth can be absorbed. If you're taking other medications, that can affect it. And then, like we said before, if it's enteric coated or sustained release, those are going to be absorbed differently through our GI tract. We can get medications sublingually, which means under the tongue, or buccally, which means in the cheek. I always remember buccal has two C's in it, so I'm like cheeky cheek. Buccal means we put it into our cheek and the medication dissolves right into those mucous membranes on our cheek. Now, if you put a medication under your tongue or in your cheek and you start swallowing a lot faster before it can completely dissolve into those mucous membranes, that's going to affect how much of the medication is absorbed into our circulatory or systemic circulation. If we allow it to dissolve right there under our mucous membranes, it's going to start to act quite quickly. That's why we give nitroglycerin for people who have heart attacks. We give it sublingually under the tongue because it will start working. Those mucous membranes will get into the circulatory system much quicker than a pill that has to go through the GI tract. We also have mucous membranes in our rectum and in our vagina, so we can give medications into those areas that will dissolve and pass through those mucous membranes and start to work in our bodies relatively quickly. When we inhale medications through our nose or our mouth, your inspiratory effort, how much and how fast you're breathing, how deeply, that can affect how fast that medication is absorbed. However, when we do medications via inhalation, it's usually a pretty rapid absorption through our alveolar capillary networks. When we give medications intradermally or topically, we're close to the epidermal cells. However, the absorption is going to be slow and gradual. So it's going to affect the local system. That's why we put it on our skin to affect itchiness, things like that. But it is absorbed into our systemic system, into our blood system as well, especially lipid-soluble medications that pass through the subcutaneous fatty tissue. When we give medications subcutaneously, the absorption is through the capillary walls in that subcutaneous tissue, and they have lots of spaces in between their cells, so it's not a big barrier. Therefore, medications that we give subcutaneously, especially if they're highly soluble, that dissolve in water, those can be absorbed pretty quickly, 10 minutes to 30 minutes. However, some medications are slow and are not soluble, and those are going to be absorbed slower. How well our blood perfuses at the site of injection is going to influence how fast that medication is absorbed as well. When we inject medications directly into our veins or IV, intravenous injection, there really are no barriers to absorption. There's no cells or linings or alveoli and capillaries that they need to go through. It's directly into our circulatory system. So of course that medication is going to start acting very, very quickly on our body. It will reach the blood immediately and start being circulated throughout. For my visual learners, here's some more information about intradermal and topical medications. Those are the ones that can go through our skin, our eyes, our ears, our nose, through our rectum and vagina. They have a slow, gradual absorption through those mucous membranes first before they can get into the circulation. They act locally a lot of times. And then we have our inhalation medications, which you can see there. You can have metered dose inhalers. That's like our typical asthma medication, where they also can be called MDIs. And that's where you shake it and you inhale it directly into your lungs. You could have dry powdered inhalers. That's where you're inhaling a powder, and there's a little visual for that. And then you can have nebulizers. That's when we put medication. See that little cup on that picture? We put medication as a liquid into that, and the nebulizing machine causes it to be aerosolized into that smoke so that we can inhale it and get it into our body. When medications don't go through the GI tract, they go into our circulation or into a specific area. We call that parenteral routes. And that's going to be absorbed very quickly, 10 to 30 minutes usually, depending on if that medication can dissolve in liquid, can that medication dissolve in fat. But it's going to, if you look at the picture on the right-hand side, you can see those needles are going into different parts of the layers of the skin. And you can see that there's that muscular layer, there's that subcutaneous layer. You can also do it intradermally, which is that very, very top layer of skin, usually makes a wheal. Or you can give it directly into that vein, which is going to be absorbed, obviously, the quickest. This slide is a great visual showing how the routes of medication administration are fastest to slowest. If we give something directly into our IV, it's going to start working quickly within a minute. Or the same thing if we give it directly into our bone, which is intraosseous. Our bone has marrow on the inside, which is highly vascular. If we give medications that way, it's going to start working really fast. If we inhale that medication, or if they put it down an endotracheal tube directly into your lungs, that medication is going to be absorbed and start working relatively quickly in just 2 to 3 minutes. Sublingual under our tongue, like nitroglycerin, or sometimes Zofran and anti-nausea medication can be given under the tongue. That's going to start working in 3 to 5 minutes. It doesn't have to go through that GI tract. When we give things into our muscular system, that's pretty vascular, which means there's lots of blood vessels in it. So that's going to start working relatively quickly. IM injections can work within 10 to 20 minutes. Subcutaneous tissue, that has a lot more fat in it. And the fat is going to take a little bit longer for that medication to get into our bloodstream, so about 15 to 30 minutes. And then we've got rectal administration routes, which can be very variable depending on what's going on in there. Is there a lot of stool? Are you having diarrhea? But that can be a 5-minute to 30-minute onset of action. Then we ingest our pills. They have to go through the GI system in our liver. That's going to take 30 to 90 minutes to work. And then we've got our transdermal or topical. That can be minutes to hours. If you're putting on something topically to work right where you have arthritis, that might start working more quickly than if you're putting on topical medication that has to work systemically. The picture on the right shows that even with tablets, if you're taking a tablet through your GI system, the enteral system, if that tablet is coated, if that tablet has an enteric coating, which is thicker so that it doesn't dissolve right away, or if it's time release, that's going to affect how fast the route is and how fast it's going to be absorbed. After the absorption phase of pharmacokinetics, we have the distribution phase of pharmacokinetics, and that is how the drug is transported to sites of action by bodily fluids. So therefore, it means once it's gotten into our circulation, it has to get to where it's supposed to work. If we take a medication for a headache, it has to go enterally into our GI system, then it's absorbed into our circulatory system around our internal organs, and then it needs to get circulated up and start to work where it's supposed to and help our headache. If we have good circulation, that medication is going to get where it needs to go rather quickly. But if we have poor circulation or slow circulation, it's going to take longer for that medication to be distributed from the circulatory system near our internal organs to wherever it's supposed to start working. The third phase in pharmacokinetics is metabolism. Metabolism changes medications into less active or inactive forms by the actions of enzymes. This can also be called biotransformation. Metabolism occurs primarily in the liver, but it also takes place in the kidneys, lungs, intestines, and blood. There are many factors that can influence the rate of medication metabolism. Infants have a limited medication metabolizing capacity. They haven't developed that system yet, so medications will be metabolized slower. Hepatic metabolism can also decline as we get older, however, that varies with the individual. But older adults require smaller doses of medications due to the possibility of accumulation in the body. If they can't metabolize those medications, they could start to build up because their liver is old and not working as well. Also, their kidneys. If we have more medication metabolizing enzymes, that can also increase the rate of metabolize. That might require an increase in dosage of that medication to maintain a therapeutic level. The liver can actually inactivate some medications when they pass through it. So some medications will require not going through the GI system and going straight into the parenteral route, like sublingual or IV, because they would be too damaged and too decreased by being metabolized in the liver. Nutritional status can also affect the rate of metabolism. If someone is malnourished, they may not have the enzymes necessary to produce those metabolic reactions in the liver, and therefore the metabolism might be impaired or slower. The last phase of pharmacokinetics is excretion or elimination. That is the E in the ADME mnemonic to remember the phases of pharmacokinetics. Elimination occurs via the kidneys, via the liver, and via the bowel. Most drugs are metabolized by the liver, and that's where they undergo biotransformation. And by the time they reach the kidneys, only a fraction remains of those drugs. But the kidney is the primary organ responsible for excretion of those drugs from our body. Therefore, if our kidneys aren't working, those drugs can stay in our body longer. Those drugs can be of an increased intensity. So we have to make sure we monitor BUN and creatinine levels of the kidneys to make sure they're working well so that we can get those drugs removed from the body the way that they're supposed to. Other routes of excretion include getting medications out through the lungs, sweat, salivary glands, and mammary glands. For our visual learners, I really like this picture. You can see the medication is going in orally, go down to the stomach, and then around through the intestines and the small bowel. Some of it is straight removed right there in our feces. Some drugs come out in our feces. However, we have those enzymes in the mucus of our digestive tract, and those help get that medication into our liver. Then our liver has more enzymes that metabolize those drugs. Some of those drugs could be removed from the bile, but most of it goes from the liver straight into the inferior vena cava, through the heart, and out to the lungs, where some of it can be lost through breath. It can be excreted through our breath, but the rest of it will go from our lungs, and that now oxygenated blood with drugs in it will go back through the left side of the heart and through the kidneys. Anything that is not left over after it goes through the body is going to hit those kidneys and be excreted through the kidneys. Pretty cool visual. I like it. So now we can put all the steps together. I like to call it ADME because administration is part of the absorption process. You can see on the picture that how a drug is administered determines how it can be absorbed, how fast and how much of it is absorbed into our body. Then the drug is distributed to go to where it's supposed to work in the body, but it will pass through the liver. The amount of drug that's available after it has passed through the liver is called the bioavailability. That's going to be how much can actually go to the other parts of the body and work where they're supposed to. The next step is metabolism, and that occurs primarily in the liver. After it's been metabolized, the medication is going to be distributed by the circulatory system to its intended site of action. After the blood has been metabolized and goes to where it's supposed to work, it can then be excreted or eliminated from the body. This is a really good picture on this slide, but be sure you read the notes that accompany it to give you a great overview of the process of ADME. Now we know that medications are metabolized, and there's a word for that. When medication enters the body is decreased in the amount by half, that's called the half-life. The half-life will reflect how quickly and efficiently a medication is metabolized and excreted from the body. Medications that have a short half-life may have to be given multiple times per day to keep the therapeutic or effective level. However, if a medication has a long half-life, you may only have to give it every day. And we know since most medications are metabolized by the liver and is excreted by the kidneys, if our patients have any changes in functioning, if their liver or their kidneys don't work as well, they may get adverse and toxic effects of medications more easily because they can't get those medications out of the body like they're supposed to. Therefore, we may have to adjust the dosage and the frequency of the medication to compensate for those organs not working. Medications also have an onset, a peak, and a duration, which is how long they last throughout the body. The onset of action is how long it takes for the medication to demonstrate a therapeutic response, which is it's doing what it's supposed to do. The peak effect is the time it takes for the medication to demonstrate its full therapeutic effect. If you've ever taken Tylenol, you may notice your headaches starting to go away. That's sort of the onset of action. And then when it's fully gone, that is the full therapeutic effect. It has done what you took it to do. The medication's duration of action is how long the medication's therapeutic effects last without additional doses. For example, with Tylenol, is it going to last 4 hours or perhaps 6 hours before you need to take another dose of the medication? When we want to maintain a therapeutic level in the blood so that medication continues to be effective, we have to know about the peak and the trough levels of that medication that we're administering. The peak level of a medication is the point in time when the medication is at its highest level in the body, whereas the trough level is the point when the medication is at its lowest level in the body, the peak and the trough, the highest and the lowest. We determine the trough level of a medication and a peak level by taking samples of blood from a client throughout the day. The lab can analyze how much drug is in that blood sample to tell us if it's at its peak, its trough, or if it's somewhere in between. Now, this is very important and always an NCLEX question. To measure the trough or the lowest level of a medication, we want to draw that blood right before the next dose is given so that we know how much is left in the blood. Hopefully it's not very much when we start to give that next dose. So always know that the trough is drawn right before the next dose is given. How much is left of that dose before we add to it with the next medication? We do that a lot for antibiotics because we want to make sure that we're killing those germs effectively and therapeutically over the 7 days that we're giving that medication. Now, we've talked about the therapeutic effects, which are the intended effects of the medication, but there can also be adverse drug reactions, and those are unintended effects that can occur because of the medication that we're giving. The effects of medication occur secondary to changes in how the cells function, changes in the cellular environment, or changes in the action of enzymes in the body. When our cellular function changes, we can have a greater or a lesser response than what typically occurs. When we talk about agonists, those are medications that bind with a receptor and precipitate a greater than typical response. That's an agonist. Alternatively, antagonists are medications that bind with a receptor to block a response of the drug we're giving or precipitate a less than typical response. And the way that I remember that is that the antagonist in the movie is always the one who wants to break the girlfriend and the boyfriend up. They're the antagonist, so they want to block or bind and cause the medication not to work the way it's supposed to. Whereas the agonist is going to add to and cause a greater than typical response of that medication. Now, antagonists that compete with an agonist for a receptor site are considered competitive agonists. That makes sense. They compete with the agonist. However, if the antagonists block an agonist's access to the receptor site, they're considered non-competitive agonists. So they're not competing for it, they're just blocking it. In high enough doses, those non-competitive agonists that block the drugs can completely block the typical response caused by the agonist, and that's not good. Whereas those competitive agonists that compete for those receptor sites, you can give them in increasingly high doses to decrease the typical response by the agonist, but you won't completely block that response. Easy slide here. Another way to categorize medications is whether they're prescription or non-prescription medications. If they require prescription, they're called prescription medications. If they don't, they're called over-the-counter or non-prescription medications. The federal government is who identifies prescription medications, and those are ones that could be potentially harmful if there's no supervision of administration by a nurse or a doctor, or a physician's assistant, or a nurse practitioner. These medications are unable to be taken unless they have been prescribed by a healthcare provider. Antibiotics or anti-infectives are examples of prescription medications. Antihypertensive medications and diuretic medications, medications that make you pee more, those are also prescription medications. Analgesics or narcotics are also considered prescription medications. We can't take those without supervision. However, non-prescription, also called over-the-counter medications, don't require prescription because the FDA, the government, has decided that they are relatively safe to take without supervision. You can usually purchase non-prescription medications at drugstores, grocery stores, and any other kind of store that sells those types of products. Examples of non-prescription medications, ones that we can take without a lot of supervision, are Tylenol or acetaminophen, Advil, ibuprofen, and then diphenhydramine, which is Benadryl. We also can get some antihistamine medications like Claritin, which is cimetidine, and Tagamet. Those are also medications that the government has found to be relatively safe for us to take without specific supervision. Because medications, even when they're working right, cause a lot of things to happen in our body, we have to be very, very careful when and who we administer them to. Up to 10% of patients can experience unwanted side effects from reactions, and research shows that administration errors, giving them the wrong way, make up 60% of all drug errors. So to reduce the amount of drug errors, we have what's called the rights of medication. There used to be 5 and then 6, and now there's actually 10, but we're going to go through those. These rights were designed, and nursing students have to memorize them because they have been shown to protect the interests of the patient and the nurse, so we don't give the wrong drug or the wrong dose or the wrong person, etc. The first right of medication administration is making sure it is the right patient and the client. We usually check a wristband, we usually check doctor's orders, and then we also ask the patient to identify themselves with their name and date of birth before we give them a medication to ensure we're giving the right drug to the right person. Next, we want to make sure that we are giving the medication that has been prescribed, the correct medication. So we check the name of the medication. We use generic names because brand names could have multiple brand names for a single drug. We also check to make sure that the medication isn't expired and that the medication has been prescribed. There is an order for that medication for that patient. Most hospitals every 24 hours has a system of checks where nurses go back and confirm that the doctor has prescribed each of those medications to help prevent. So we do it at the time we administer it, and we also do it once every 24 hours to confirm that those medications have been prescribed correctly for the right person. We also want to check the prescription for the right dose. Is the dose that we're giving of that medication appropriate for the particular patient we're giving it for? For example, if someone is elderly and their kidneys or their liver doesn't work, we may need to give a decreased dose. So we always have to check the prescription and confirm that the dose is appropriate for the patient we're giving it to. Now, if you feel that it's not an appropriate dose, it is the responsibility of the nurse to make sure and let the pharmacy know or let the doctor know so that it can be adjusted. Next, we check the right route. We know that different routes of medication administration can have an effect on how they are absorbed. So we want to make sure that we are giving it in the route that the doctor has prescribed. We need to make sure that that route is appropriate for that patient and that the patient can take it. So in other words, if a patient can't swallow and they're ordered something orally by mouth, we need to go and double check that because they can't take it that way. So right route. Number 5, the right time means that we're giving the medication when it's supposed to be given. So we have to check the frequency. How often is it prescribed to be given, and that we're giving it within the right time. A lot of hospitals is 30 minutes to an hour before or after the prescribed time is when the nurse is required to take it. We also have to confirm when the last dose was given. If that nurse gave it late, we don't want to give the next dose too early. So that's the right time. Those are the first 5 main rights of medication administration, but now we've added on some more. If you can remember the acronym Doctor Time, you can remember 6 out of those 10 rights very easily. So doctor, D-R-T-I-M-E. The D in doctor stands for dosage. The R in doctor stands for route. The T in time stands for time. The I in time stands for individual or person. The M in time stands for medication. And the E in time stands for evaluation. So if you can remember Dr. Time, you're going to get those 5 really important medication routes of administration, and then you're just going to need to remember the other 4. Another way to remember the first 5 rights of drug administration is to remember the mnemonic TRAMP, which stands for, the T stands for time, the R stands for route, the A stands for the amount, the M stands for medication, and the P stands for patient. So either one of those mnemonics is going to get you half of those rights of drug administration. Use whichever one you prefer. The prescription order is where we get all of that information to do our 10 rights of drug administration. We will receive an order from a doctor for a drug, and these orders must have all of the parts seen on the slide in order to be a complete order. If they're missing anything, it's our job as a nurse to ensure we contact the doctor and make sure that those parts are in the order. You can see those parts of an order are the client name, and then the example, it's Haley Greenbaum. The date of the order, this one's from way back in 2021. The name of the drug, here it's amoxicillin. The dose is going to be 500 milligrams. The route to be given is PO, which means by mouth, so that's going to be an oral medication. The frequency is BID, which means twice daily. The duration is going to be for 10 days, and then you always have to have a provider's signature. If you receive an order for a medication over the phone, you have to, number 1, ensure that all these parts are given, and number 2, you have to read back the entire order to that doctor so that he hears you say all the parts to make sure that they are correct. Then that doctor has to come around within 24 hours and sign any verbal order that you took over the phone. It's always much better to have a written order than a verbal or telephone order, because then it's in the doctor's hand, and all we have to do, especially in most hospitals, now the doctor can just type it, so we don't even have to worry about handwriting or if he said the wrong thing. It's always better to have a written order than a verbal or telephone order. Now we're going to talk about some special considerations that we need to keep in mind when we are administering drugs to our patients. The first thing is adverse versus side effects. Now, a side effect can be something that happens when you give a drug that could be mild and annoying, like pain medicine can cause sleepiness. Sometimes it can be tolerable. If your stomach gets a little bit upset, you can just take with foods or gum if medication makes your mouth dry. Those are side effects. Sometimes we have to change if you get something like fainting or insomnia, you can't sleep. So those are side effects. Adverse reactions can be serious and sometimes life-threatening. If a patient has an adverse reaction, we are not going to continue to give that drug. One of the most common adverse reactions is anaphylaxis, where the patient has an overreaction to the medication, and it can cause problems with breathing. It can cause problems with our blood pressure. It can make our blood pressure crash, and we can actually eventually go into cardiac arrest. So if someone has an anaphylactic reaction to a drug, we absolutely do not want to give that drug to a patient. We also have to be monitoring to ensure that our patients who might be getting a new drug are not going to have an anaphylactic reaction. And if they do, that we get it treated immediately by stopping the drug, giving something to reverse the drug if we can, and to maintain their heart rate, their blood pressure, and their respiratory status. Adverse reactions can also be bleeding. If you take too much of a blood thinner or you have an adverse reaction, we could also have liver or kidney damage from a medication. We would have to stop that right away. Sometimes we can have an idiosyncratic reaction, which means it does sort of the opposite of what it's supposed to do. So some people can take Benadryl, which makes most of us sleepy. That's a side effect, right? Benadryl is an antihistamine, but it can also make us sleepy. So sometimes we take it to put us to sleep. But little kids and some people, Benadryl can make them stay awake forever. They can have insomnia and they aren't able to go to sleep. That's a paradoxical reaction. It is something that does not occur in most patients, but can, and it's still going to be an antihistamine, but it's a side effect that we definitely don't want. Patients can also be on a whole multitude of medications. That's called polypharmacy, and sometimes medications can react with each other. So we have to be very careful when our patients are on multiple medications. Another consideration to keep in mind is that pediatric medications are usually weight-based because a 2-year-old can weigh a vast array. You've seen little tiny 2-year-olds and really big 2-year-olds. So medications for those pediatric patients, our children, are usually weight-based. And we already talked about how newborns and infants don't have those enzymes yet to help metabolize and to absorb those drugs. So a lot of times they have poor absorption of oral medications. They can get low blood pressure, or they can metabolize them even quicker than they're supposed to. So we have to be very careful with those newborns and infants. Adolescents go through growth spurts, which can affect how drugs react in their bodies. And older patients, everything starts to slow down. We have our heart doesn't work as well, so we have lower cardiac output. Our liver and kidneys may be impaired and don't work as well. And so our side effects and the effects of the drugs may be more severe as we get older. So we have to be cognizant and watch out for those kinds of things. Even ethnicity can be a consideration when we're giving a drug. It has been shown that Asian nationalities can have a greater response to blood thinners and may need a lower dose. So we have to even keep in mind what ethnicity a patient is when we're giving them drugs. African American people have been shown to have a greater risk for hypertension, so they may need higher doses or multiple hypertensive medications. And finally, we have pregnancy. We want to avoid drugs as much as possible during pregnancy because they can have an effect on the child. They can cause birth defects, which is called being teratogenic. That means that these medications can cause birth defects if a pregnant mom takes them and it's passed on to the baby. So any medication that a pregnant woman takes, the benefits, the reason that she's getting it needs to outweigh the risks to that fetus. The notes on this slide have a lot more information on adverse drug reactions and therapeutic uses and pharmacological actions. So go ahead and make sure you read the notes for this slide. Okay, now I'm going to hit you with some effects that you have to monitor for when you're giving your medications to your patients. Medication tolerance is the body's decreased response to a medication it receives over a period of time. In order for that medication to continue to work and exert a therapeutic effect, you have to increase the doses. When people use opioid analgesics or pain medicines for long term, they often have to have their doses increase, and that's called pharmacodynamic tolerance. So a tolerance is different than a medication dependence. A medication dependence is a physiologic or psychological need for a medication. Our brain tells us that we need it and we need it more and more. If a patient is psychologically or physically dependent on a medication, if they stop getting it, withdrawal symptoms can occur. And withdrawal symptoms include a variety of physical and mental manifestations. A medication interaction is an alteration in the expected pharmacological action of a medication that results from an interaction with another medication. Patients can also become sensitive or experience medication sensitivity, which is a cumulative effect, meaning it happens over time in patients who have changes in their bodies, like when we get old, or if you have impaired liver or kidney function. Then you might not be able to excrete those medications and you may become sensitive to that medication. Finally, we've got medication toxicity. That occurs when a patient receives medications in excess or above and over their regular dosages or the dosage needed, which can result in negative physiological effects. Their body's going to have effects from that. It's very important that we always prescribe the lowest effective dose possible to achieve therapeutic effect. I'll say that again. You always want to make sure providers are prescribing the lowest effective dose, meaning it's a therapeutic dose, it's doing what it's supposed to, the lowest effective dose as possible to maintain those effects. If those medications are overprescribed, or if you have a problem with your liver and or your kidneys, they could build up and reaching a toxic level, and then that creates toxic effects. So we always want to make sure we're checking our patient's liver and kidney functions. Medication toxicity can be irreversible and life-threatening. It's a big deal. For example, patients who receive vancomycin, which is an antibiotic, if they get doses that are too high, it can actually cause them to lose their hearing and become deaf. That's pretty scary. Acetaminophen can cause temporary damage or even permanent damage to the liver. That's why we're going to learn the maximum dose of Tylenol patients can receive in a 24-hour period, which obviously would be less in the elderly because their kidneys and their liver isn't going to be working as well for most of those guys. Again, we have to be really, really careful and take extra precautions when doctors prescribe medications that have the potential to cause an adverse drug reaction, especially in the elderly or in children or in people who have polypharmacy, they're taking lots of meds together, or if they're taking certain foods. Grapefruit juice is a good one that can affect certain medications. So we always have to make sure that we take the appropriate precautions. We also want to make sure that these medications are only given when the benefits outweigh the risks. People who have multiple medical conditions are also going to be at risk for contraindications, or we need to make sure we take extra precautions. Your book gives a good example of a patient who might have a hemorrhagic stroke, so where your brain has a bleed. They might be in a hospital bed and require more anticoagulation or more blood thinning so that they don't get clots in their legs, right? But we really have to measure, does that benefit outweigh the fact that we could cause a bleed in their brain? Other times we just have to limit certain types of food or administering medications at the same time as one another, spacing them out throughout the day instead of restricting the medication itself. Now, this is important. A boxed warning is the highest safety warning the FDA, the government, can place on a group of medications within a class. If you are giving a medication that has a black box warning, we always have to be extra aware for the potential of serious side effects that may be caused by that medication. When we talk about contraindications for medications, that means that there's some meds that a provider should not prescribe because they have the potential to cause serious or life-threatening adverse drug reactions. Those medications are absolutely, we don't take precautions with those. Those are contraindicated. We cannot take those medications together or that food and that medication together. They are contraindicated. Like I've said, medications can react with other medications, and medications can react with foods. These interactions can radically change the action of medication in the body. That's not a good thing. Your book gives the good example of grapefruit drink that can decrease the enzyme metabolism of certain medications, which increases their potency and the risk for toxicity. The one I like to remember is tetracycline, which is an antibiotic. The calcium in milk can bind to that drug, reducing its absorption. Another contraindication would be eating dark green vegetables like avocados that are high in vitamin K because they can counteract the anticoagulant, the blood thinning effects of Coumadin or warfarin. We've already talked a little bit about how as our body changes throughout the lifespan, from an infant to a child to an adolescent to an adult to an older adult to the elderly, the octogenarians, medication therapy needs to be altered to go hand in hand with these changes across the lifespan. We also have to be, again, very aware of how when a patient is pregnant, many medications and foods can cross through the placenta and get into the fetus through the umbilical cord. So we really want to make sure to limit the amounts and the kinds of medications that pregnant women are taking so they don't get into the fetus. As our patients' nurses, it's important and it's our responsibility to help clients know what medications they're taking. Besides knowing what medication they're taking, they need to understand and know the purpose. Why are they taking that medication? The generic and or brand name of the medication, the proper method and schedule for administration. When is this medication supposed to be given? Potential adverse drug reactions. What should they not eat? What medication should they not take if they're taking this particular medication? And then any precautions the client needs to take during therapy. This last slide gives you a summary of some of the key points that we talked about, some of the definitions, and some of the things that we've discussed in this presentation. I want you to make sure you are very familiar with the bullet points on this slide, as well as all the information that we covered. Thank you for your time.